Good morning, everyone. This is Rochelle Seeger with the Foundation for a Healthy Kentucky. Thank you so much for joining us here this morning. I'm proud to present a Health for a Change webinar, COVID-19, Health Equity in Kentucky Beyond this Pandemic. I'm honored to work at the Foundation for a Healthy Kentucky on the data initiatives, including this training series. The Foundation for a Healthy Kentucky's mission is to address the unmet health needs of Kentuckians. The Foundation does that by developing and influencing policy, improving access to care, reducing health risks and disparities, and promoting health equity. The Foundation's website, healthy-ky.org, you can find information about our organization, our research, our data, news releases. You can also sign up for the Foundation's newsletter there at healthy-ky.org. Finally, this training series. The Foundation launched Health for a Change training series to support the nonprofit and health advocates across our state. This training series is free of charge and open to everyone. We have 3 upcoming webinars. June 15th, we'll be talking with Virginia Bradford, a nurse who works in the cancer space. June 26th, we'll be talking with Valerie Horn in Whitesburg, Kentucky. And on July 10th, we'll be talking with farmer Michelle Howell, who's from Scottsville. I'm glad you all are here today. A reminder that a recording of today's webinar and the PDF of the slide deck will be posted very soon to the Health for a Change website. Finally, the Health for a Change webinar series is made possible by partners just like you. We're honored to have worked with the Kentucky Center for Smoke-Free Policy, Jessica Bellamy's Design House, Louisville Free Public Library, Kentucky Youth Advocates, and many, many others across the state of Kentucky. So I'm thrilled that you've joined us here today. Now I'm going to turn over the call to the moderator on our call today, Vivian Lashley-Bibbs. Vivian is Vice Chair of the Foundation for a Healthy Kentucky Board of Directors and Director of the Office for Health Equity, Kentucky Department for Public Health. Welcome, Vivian.
Good morning, everyone. Thank you for joining our webinar series. This webinar will highlight actions organizations are taking to address inequities and disparities and minimize the disproportionate impact of COVID-19 on our marginalized and vulnerable populations in Kentucky. Specific examples of both positive outcomes and new or lingering barriers will be shared. We'll hear from organizations serving an urban population and the rural population. We'll also discuss upstream issues, including societal and structural factors that create inequities and disparities and what the state can be doing to advance health equity. The purpose of this webinar is not just to talk about the issues, but find ways to start addressing them both for the current pandemic and beyond. I'll be introducing each speaker before their presentation, and there'll be an opportunity for questions to be answered by our panelists. Please put them in the chat box, and I'll respond to them in the order in that they're received. So first up this morning, I'd like to introduce Dr. Anita Fernander. Dr. Fernander is an associate professor of behavioral science in the College of Medicine at the University of Kentucky. She received her PhD in clinical health psychology from the University of Miami and holds a master's degree of the same, and also holds 2 bachelor's degrees, one in physical education and the other in psychology, from Oakwood College, now Oakwood University, a historically black college and university in Huntsville, Alabama. Prior to arriving at the University of Kentucky, she completed a postdoc fellowship in medical psychology at the Mayo Clinic in Rochester, Minnesota. Her primary area of research and teaching has focused on examining the impact of race-related stress on health disparities among African Americans. Her current scholarly passion is focused on increasing the number of underrepresented minorities in medicine, training and mentoring students and faculty regarding cultural humility, and promoting diversity, inclusivity, and equity in academic medicine. She's also founder and chair of the Lexington Fayette County Health Disparities Coalition. So at this time, let us welcome Dr. Fernander.
Thank you so much, Leslie. I want to thank the Kentucky Foundation for Health for inviting me to participate on this very, very important webinar. And today I'm going to talk about health disparities through the lens of COVID-19 and ask the question, hopefully, that will prompt many of the listeners and participants to spend some time thinking about, is the United States ready for a social justice approach to health? So from the time COVID-19 became apparent in the U.S., it became evident that communities of color were disproportionately burdened by the virus. In almost every state where racial data is available, African Americans have higher cases of exposure, infection, hospitalizations, and deaths due to COVID-19. And these findings aren't surprising, as history has revealed that severe illness and death rates are higher for African Americans during public health crises. The COVID-19 pandemic and recent attention to African Americans dying at the hands of police have laid bare stark structural and systemic racial inequities. While these two epidemics have brought health and health care disparities into sharp focus, they're not new. And understanding and recognition of the structural and systemic barriers that underlie these disparities is needed to catalyze the work required to address them adequately. So there's a common refrain known among many African American communities. When white America gets a cold, black America gets pneumonia. In the case of COVID-19, the refrain might be, when white America gets the flu, black America dies. This refrain reveals the fundamental reality of persistent structural and systemic inequalities that have existed in the U.S. for centuries that lead to health inequities among African Americans. Crises place a magnifying glass on the realities of inequity that have remained unrecognized or ignored by the larger society. So it's clear that individuals with pre-existing chronic conditions like diabetes, hypertension, COPD, cardiovascular disease are more susceptible to COVID-19 related morbidity and mortality, and it's documented that African Americans bear a disproportionate burden of morbidity and mortality due to these chronic pre-existing conditions. And while it may be expedient to point to genetic differences, individual behaviors, or other racialized myths as the cause of pre-existing chronic conditions and COVID-19's susceptibility among African Americans, it must be emphasized that these pre-existing chronic illnesses are not accounted for by inherent biological predispositions due to race, but are in large part due to systemic and structural pre-existing conditions that we often refer to as the social determinants of health. So what are social determinants of health? They are conditions in the environments where individuals are born, live, work, play, pray, and age that include factors like economic stability, neighborhood and physical environment, educational opportunities, employment, community and social context, the healthcare system, and racism that is both embedded within these social determinants and racism that is a part of the day-to-day personally lived experience of African Americans. And these social determinants account for up to 80% of health risk. I want to briefly highlight some of the racial inequalities in the social determinants of health that contribute to general health inequities, including the disparate impact of COVID-19 among African Americans. Financial stability is a fundamental risk factor. Key variables include poverty, wealth, and employment. So when it comes to poverty, African Americans are more likely to be poor. They have twice the poverty rate and significantly lower household income than white Americans. As it pertains to wealth, on average, whites have approximately 10 times the wealth of African Americans, and one of the most important ways to initiate wealth is through home ownership. Home ownership for African Americans is 41% compared to 73% for whites due to lack of inclusion in the financial system and redlining policies that continue to this date. And I want to add that rate of 41% of home ownership among African Americans is the same rate as it was in 1968. When it comes to employment and wages, there exists a history of occupational segregation by race, with nearly 25% of African Americans employed in the service industry compared to 16% of whites. African Americans with similar educational levels as whites make less for the same jobs. African Americans are twice as likely to be unemployed than their white counterparts. And African Americans' overrepresentation in essential service jobs places them at higher risk for COVID-19, as they are unable to shelter in place, practice physical distancing, or work from home. So the economic gap between African Americans and whites indicates that during COVID-19 and subsequent months and years, African Americans will likely experience more bankruptcies, insolvencies, and job losses. Educational attainment is a well-established social determinant of health. Key factors that impact education include early childhood education and development, high school graduation, and enrollment in higher education. African Americans have less access to high-quality education at every stage. Only 19% of African American children attend early childhood education programs compared to 42% of their white American counterparts. African American students are more likely to attend schools that are separate and unequal from kindergarten through high school, even though there was a government mandate over 70 years ago to correct this inequality. And the unprecedented disruption of COVID-19 on education highlights a racial digital divide that will likely amplify educational disparities among African American youth. Place matters when it comes to health. Your zip code matters more than your genetic code. Since the 1930s, racialized redlining has continued to shape neighborhoods and environmental living conditions of African Americans. Health is adversely affected by neighborhood characteristics such as air pollution, poor water quality, lack of available green spaces, and distant healthy food options. The African American poor frequently live in substandard housing that lacks adequate heat, hot water, and electricity, and have high exposures to mold, asbestos, lead, and pest infestations. The 10 U.S. counties with the highest food insecurity rates are all at least 60% African American, and African Americans are twice as likely to experience hunger than whites. Interestingly, African Americans of all socioeconomic levels are exposed to higher levels of air pollution and live in close proximity to toxic waste sites. Majority African American communities are least likely to have access to hospitals and other healthcare providers. Some of the key factors that often interact to impact community and social context include social and economic cohesion, homelessness, the criminal justice system, racialized policing, and civic engagement. Political underrepresentation and disparities in public services and investments in public goods makes African Americans less likely than whites to live in communities that facilitate social and economic development and mobility. When it comes to homelessness, African Americans make up 40% of the homeless population and are overrepresented in every state across the country. The homeless spend more time in public. They can't stay home as directed by the CDC. They're less likely to have access to soap and water and places to wash and bathe. They rely on shelters for meals and showers. Many of these shelters have not been able to fully function and operate due to COVID-19. When we think about racialized policing, as authorities have implemented COVID-19 restrictions, the potential for biases in policing practices and over-policing is higher and has been evident during COVID-19. The incarceration rate of African Americans in prisons or jails is more than 6 times the white incarceration rate. And there's been a surge of COVID-19 among U.S. prisons. When we consider civic engagement, we continue to see evidence of bias in voting rights and access through rigid voter ID laws, voter purging, the closing of polling locations in African American communities, and voting restrictions that are placed on those with criminal records. In this election year, COVID-19 restrictions has exacerbated these issues and has the potential to lead to limited civic engagement on the part of marginalized communities. African Americans are least likely to have medical insurance. They're more likely to be underinsured. They're less likely to see a medical provider due to cost, least likely to have a primary care provider, and more likely to incur substantial medical debt than their white counterparts. And early reports have indicated that access to COVID-19 testing and treatment has been disparate. Almost 250 years of enslavement, where minimal or no health care was provided for African Americans, even though their bodies were abused for medical experimentation without benefiting from the medical advances of those experiments, plus 100 years of Reconstruction and Jim Crow segregation, with unequal and inadequate health care facilities, access, and treatment for blacks, and an additional 55 years of civil rights where racism and implicit bias continues to impact clinical interactions and treatment outcomes, equates to over 400 years of historical and contemporary dehumanization of African American bodies and inhumane health care. Furthermore, the interpersonal and individually mediated lived experiences of white racism triggers epigenetically influenced responses that damage immune, hormonal, and neuronal physiological processes that lead to negative physical and mental health outcomes, exacting a heavy toll that scientists have linked to higher rates of morbidity and mortality. Because an individual's health is significantly determined by social factors, and the existence of health disparities are due to structural and systemic factors that impact the social determinants of health, it follows that a social justice approach for addressing health disparities be undertaken not only in pandemic crises, but in times of normality when crises are not as apparent. Healthcare professions training institutions, health systems, community coalitions, and federal, state, and local governments are all needed to implement actionable and sustainable upstream social and economic policies and interventions directed toward eliminating health disparities in marginalized communities. Thank you for your attention this morning.
Thank you, Dr. Fernandez. That was a great historical timeline for us and really giving us context for what we're talking about today, and I think it leads right into our next presenter. If Sadiqa Reynolds is with us, I'd like to introduce her this morning. Are you with us, Ms. Reynolds? If she's not, then we would like to go out of order for just a minute with Dr. Feltner.
I'm here.
All right. Oh, so thank you. There she is. All right. Good morning, Ms. Reynolds. I'd like to introduce you this morning and then have you do your presentation. Are you with us for a limited time, or are you going to be around for the question and answer at the end? All right. I'll introduce Ms. Reynolds. She's former District Judge Sadiqa Reynolds, the first woman to serve as president and CEO of the Louisville Urban League. Her work on jobs, justice, education, health, and housing has garnered the attention and coverage of CNN, Fox News, the New York Times, and other national media outlets. She was the first African-American woman to clerk for the Kentucky Supreme Court and also the first African-American to serve Kentucky as an Inspector General. She's also run a private practice, handling criminal defense matters and representing abused, neglected, and dependent children. In 2017, Ms. Reynolds was named Community Leader of the Year by the National Alliance on Mental Illness for her work to reduce the stigma around mental health. She's a proponent for restorative justice and has been a participant in the Face It campaign against child abuse. Ms. Reynolds has been recognized as a Business First Enterprising Woman to Watch and a Woman of Influence. She's received numerous local, state, and national honors and awards for her justice and housing advocacy work. And the most recent award is the 2018 National Urban League Woman of Power and the Audrey Grievous Community Enrichment Award recipient. Without further ado, Ms. Reynolds. We'll give Ms. Reynolds one more minute to try to log on. If not, we'll go out of order and we'll catch her when she comes back in. Rachel, I think Ms. Reynolds is trying to get in. If we can assist her, she's put something in the chat for us.
Yes, we're trying to get her on the phone line. There's a phone line for her to call in the box. Thanks, everyone, for being patient. We are doing our best to get ourselves together here on this Friday. So thanks, everyone, for staying on the line. One moment.
Hello.
Good morning, Ms. Reynolds. How are you?
I'm fine, thank you. How are you?
Doing well. We've already given you your introduction, so if you're ready to proceed, we'd like for you to go ahead, if that's all right.
And remind me how long I have, 20 minutes?
20 minutes, please. Yes.
Okay, and so am I going to be able to see what you all are doing here? Okay, I guess I just have to roll with it. All right.
Yes, you have control on your side.
I do?
Yes, you do.
I'm not controlling anything. Oh, there's slides here?
Oh, okay, there you go.
Okay. All right, I'm just going to stay on this one, right? This is the only one that I have, or did I send slides?
I don't have them. If you sent them, Rachel should be able to answer that. Rachel, do you have slides for Ms. Reynolds or no?
Nope, this is the slide. So go ahead with your presentation. Thank you for joining us today.
Thank you.
You so much. Hello, everyone. I am Sadiqa Reynolds, President and CEO of the Louisville Urban League, and I am very excited to be with you all today. Please bear with me. I may not be as great at presenting to people that I can't see, that I'm not getting any sort of response from. I think that is just a little bit complicated. I don't even know if we have chat here, so this should be interesting. But I want to, is there some way for you all to at least tell me that people can hear me so that I feel a little bit better about that?
We can hear you.
Yes. Okay, very good. So I'm Sadiqa Reynolds, President and CEO of the Louisville Urban League, and our focus is and has been jobs, justice, education, health, and housing. The reason for that focus is because we believe that to be a holistic approach to the things that are broken in our community and in our country. I think this is a trying time for all of us, for Black Americans certainly, and I think for others who are observing and who are living with and through the pain of the protests that are happening. And I think that we have to talk about how this impacts our health and how racism impacts the health of our entire communities, not just Black people, but all people. I think that it's really important, and it's time for us to have these very, very serious conversations about what is going on and what is going wrong, what we have allowed, how we have allowed certain people to live in this country, under what conditions they live, why we have some of the circumstances we do. I think it's just very important for us to really be honest about those things. And if we're not willing to confront our own flaws as a country and as individuals, as corporations or whatever, if we're not corporate leaders, if we're not really willing to do that, then we are going to be stuck in a cycle of violence that is beyond just protesting, because one thing that we do need to say, the violence on the streets that you see, I mean, in large part we have very, very peaceful protests, and you have people who are just out there raising their voices, and they are being peaceful. but you also do have some things that have led to violence. But it doesn't come close to comparing the violence that has been levied against black bodies, and mostly while aligned with white silence. And I think we have finally gotten to a place in the road where we want it to be clear to the world that if you are not for us, you are absolutely against us. And what we need, and I say we because you can't see me, but you see this picture. I am a black woman from the South Bronx, New York. I've lived in Louisville for quite a while, since I came here for college and went to Lexington for law school and came back. But there is no sense that black people have access to the same justice as white Americans, to the same anything. Not when it comes to the criminal justice system or police, not when it comes to workforce, not when it comes to education. There are so many deficiencies. And we know, because you all are smart enough to know, that this is intentional, right? There's intentional structural racism that we are fighting against, and we continuously want to start new programs. We do a lot of studying, but we don't do a lot of action to really change outcomes, to dig deep into root cause challenges about why we are where we are. And so let's just start, for me, running the Urban League and thinking about the pandemic. If you can imagine all of the stress of serving people who have been disempowered and disenfranchised and are already in many ways struggling just to get by, struggling to manage a world that clearly says every day to them that their life doesn't matter. And not in big ways all the time, not in big ways like police knocking down your door and killing you, but in small little ways every day that you have to explain your existence or your anger in some cases, or your passion is too much for people, or constantly trying to navigate a world that doesn't want you, impacts your health, impacts your quality of life, impacts your sense of self, everything. So we already had that. And we are also pushing companies to hire people, give them an opportunity. If you hire someone who is black and they fail or they don't meet your expectations, it's not a good fit, don't just walk away from the whole group of people, right? Let's keep going here. And so all of that is happening, and COVID-19 strikes. And at the time that the Urban League, like other organizations, like big companies across the country, decided to send staff mostly home to work. We actually never closed the building because we understand who we serve and that there would be people who couldn't reach us by phone and couldn't reach us by email, and they would just come by. So we never allowed the building to be closed, but we mostly sent people home. And at that time, when we are trying to figure out financially how we can make it, what grants we can still perform, what business has to change, we also find out that a young woman has been killed by the police at home in her house. And the way it was described to us, like the rest of our city, was that the police were serving search warrants on 3 residences, and one of them, when they went in, the male suspect shot, fired, hit one of the officers. Officers returned fire, and the female suspect was killed. And this was a drug house. That was the way it was presented. And so we're dealing with COVID-19. Now we are also dealing with a police killing of a black female suspect. And then, originally, you'll recall that many people, and certainly in the black community, believed that this was something that we would be exempt from. Because in Louisville, the first people we heard about testing positive for COVID-19 were some very wealthy people. And so there were rumors that if you hadn't had any international travel, you know, this is not about you. And so honestly, there was sort of this thing that, okay, maybe poor people are safe. maybe we finally, thank God we couldn't afford the first class seat. Well, of course, that was that myth was debunked pretty quickly for most of us, but it took a while. And we had to work with many of our clients. We still had construction classes going on virtually. We were testing people in the parking lots just so that they could take the national test that they needed to take in order for us to get their certification. And each time we would gather them, even virtually, we would remind them that, you know, COVID-19 is a real thing and it can impact you. In our community, we have these underlying conditions, and you have to be more careful and think about what you're taking home to your parents or your grandparents or your children, whatever. And we had to navigate all of that in the middle of, you know, also trying to, again, navigate all of the things that poverty and racism have already poured onto you. And this idea that, you know, I thought you please think about the children who were sent home from school and the parents who were not prepared to buy breakfast, lunch, and dinner for those children because the plan was that they would be in school. And so automatically you have this strain on your financial resources. And how do you manage? And now your child, you have to stand by, and maybe the school is going to get them a laptop. Maybe they're not. You're not sure if they qualify. And then if they do and when they do, how do you help with managing to turn in the homework or do what's necessary or monitor all of that as you navigate this system of life that is so unfair, unjust, and inequitable? So we've watched and we've helped and we've walked our clients through this pandemic. And at some point, I remember that Eli Lilly, and you all certainly know this, put a cap on the cost of insulin drugs. So insulin now, I think there's a cap of $30 or $50. I don't quite remember. If somebody does, you can type it in, and I'll say it out loud. But it's the $30 or $50. And we thought here at the Urban League, my goodness. So all of a sudden, when we realize that there is this infection, there is this disease that will travel just by virtue of you and I being in the same space, you know, and maybe just the spit from normal conversation could ultimately kill you. All of a sudden now, insulin has to be taken every day. We want to take care of people with these underlying health conditions. And we see that in the black community as this is not about taking care of us. This is about recognizing that we are overwhelmingly represented as essential workers in this country. We are the ones cleaning the bedpans. We are certainly not the only ones, but again, overrepresented in that regard, overrepresented in those bus drivers that can't work from home, overrepresented in those grocery stores. And so all of a sudden, the people you need to do the work, our country sees it has an interest in keeping them healthy, not just so that they would be available to work, but because if you're near these other people, we don't want you to make them sick. And so over and over again, we are shown that this country knows how to be humane. Our leaders know how. Our police department knows how. There just seems to be no interest until it is in the interest of the greater society. So until you can figure out that even standing near me might kill you, might hurt you, might harm you, then it's a game changer. And I've got a note here that the cap on insulin is $35, and that's still in place. The other thing you may not have known is if you were on SNAP benefits, you could not use things like the Kroger Click List, were not available prior to COVID-19. It's really been a couple of months since food stamp recipients were actually able to order in that way. So you think about, it's like this is a luxury that only who should be exposed to, because if you're on SNAP, surely the least you could do is get your ass up and go to the grocery store. You couldn't possibly have any underlying condition. You couldn't possibly be unhealthy, right? Everybody using the system is just gaming the system. And, I mean, that's what it feels like. That's the way it feels like people are treated. That's the way it feels like these systems are created, sort of to keep out the abuse as opposed to serve people who really honestly need help. So I want you to really think about that. Think about these things in different ways. Now, I'm looking at COVID-19. Well, I'm reading some of the questions, I'm sorry. Was the communication and messaging around COVID-19 reaching the African American community? The communication and messaging around COVID-19 was reaching the African American community. But some of the younger people, it was not reaching them. And we had to go out. We used every opportunity we could when people were coming for jobs or when we had those groups together to explain how serious it was. And in fact, some of the African American leaders got together. We all created a commercial ourselves just to put out on social media, and then the mainstream media picked it up and ran it a little for us. So we definitely need non-traditional ways to communicate. The other thing we did, though, we partnered with Norton Healthcare to provide COVID-19 testing. We threw these testing sites together at the Urban League in like 48 hours generally, and we were able to test over 800 people, or around 800. So, and we made sure that those being tested were people who lived in community and were the people who were more at risk, because what you find sometimes is you set these test sites up, and then people who have access to the internet and they're, a little more time on their hands or whatever, they end up coming into community and taking the benefit of these good things that we have. So we first communicated with our staff and then our clients and our urban senior job program folks. I mean, we have 55 and over seniors, low-income seniors, so we made sure all of them were in line first, and then we opened it to the public. So the demographics on our testing site reflect the community that we sit in and serve. And, of course, the Urban League serves everyone, but obviously we're a civil rights organization, so most of who we serve are African American. Someone is asking a question, what has been the Foundation's response to equity as it relates to the risk essential workers have taken to keep Kentucky's economy open? These individuals usually representing overwhelming number of people of color. I don't know what the Foundation's response has been. I'm sure somebody can answer that. But I can tell you I am not sure any place has had a good, solid response because, quite frankly, nobody really wants to put their money where their mouth is. That would include the Foundation as far as I'm concerned. I have not, first of all, there's not enough investment in black leadership in this town, in this state, in this country. There's not enough commitment to financial resources. if you understand that communities have been redlined out of opportunities, if you understand that there are entire groups of people who have not been able to acquire wealth, die, and pass that wealth down, and you don't respond with financial resources, then you are putting Band-Aids on. People have to, we have to change economic outcomes. If you really want to change health equity, you have to also change, are we investing in small businesses? Why does that matter? It's a quality of life issue. Think about the barbers and the stylists who rent space for 20 years in the same location and never have the opportunity to buy the building. So they die and leave their families nothing. They were entrepreneurs. They worked for themselves all their lives, but what's on the other side of that? There's no wealth in our community, or there's not enough wealth in our community to really invest in our dreams and ideas. That not enough for somebody black could never be Trump and be the president of the United States. I mean, think about the opportunity he has had to fail or to prosper because of the financial resources. Now, I understand that most Americans are not situated in that way, but it's still a good example of the lack thereof in our communities. So let me talk about for a minute dealing with COVID-19 on top of, or dealing with police brutality on top of COVID-19, please. So I just told you we had the shooting, and that was in March, just as everything was closing and everything was crazy and we were all scared and didn't know if the world was going to end. And then the details of the police shooting begin to come out. And there are all of these contradictions. We realized it was not a drug house. In fact, there were no drugs found. We realized this woman was an essential worker. We realized this woman has no criminal record. We realized the man in the house with her is not the man who is alleged to have been the drug dealer. He is her boyfriend. We realized the police definitely knocked, but did not announce themselves. And we realized that Kenny Walker, the man who shot officers and was in the home with Breonna Taylor, is sitting in custody. And so you begin this sort of crying out, why is he in jail? He says he didn't know it was the police. And there was a push then for the 911 tape. There was a push to hear, because we all knew, his lawyer said, there are 911 tapes. Breonna Taylor's family said there are 911 tapes, but they would not release those. And while that's happening, George Floyd is videoed or recorded with a police officer's knee in his neck, cutting off his air and killing him in the street. And our community is again traumatized. Trauma on top of trauma on top of trauma. So, the country erupts. In the middle of a pandemic, our country erupts in protest. And people who complained that Kaepernick was disrespectful and disruptive when he kneeled on the football field during the national anthem. And he kneeled upon advice from his colleague, who was a veteran, who said it would be more respectful to kneel rather than sit. So he followed his instructions, and he kneeled peacefully during the national anthem on Sundays. And people said he was disruptive and disrespectful, and black people watched as his career was destroyed, his ability to earn money ripped from him, and now those people want to tell us how to protest, how to raise our voices. We don't need the looting. I do not condone it, but I understand that I live in a country that only responds to economic damage. There is no evidence that black life matters. There is absolutely no proof of that. And before George Floyd, we were already struggling with Ahmaud Arbery. We were already trying to figure out what happened there. If you don't remember him, because it does seem so long ago, but it wasn't, Ahmaud was out running in Georgia, and 3 white men attacked him. They taunted him, and they murdered him. And one of them made a video of it. And he was stupid enough to think that video would help. Before we saw that video, we were told that Mr. Arbery was a thief, he was a burglar. So not only do we get killed on video for the whole world to see, but our stories get stolen. It is impossible to be black in this country and not be traumatized right now. We want peace, but not without justice. We want good people to stop being quiet when our lives are slowly picked apart. We want good people to invest in ways that change outcomes for people who have no control over policy. We want people to be outraged when we die, whether it is from lack of insulin because we cannot afford it, or police brutality. If, in fact, my life matters, show me how. So today, from my perspective, and I have to tell you all, I'm emotional. I live downtown in Louisville, Kentucky. Last night, someone set off some sort of explosive device near my house. I understand, and this is crazy. All we are asking for is for police officers to be terminated, to be suspended without pay until you figure out what happened. But not even. We can't even have that. And this is the frustrating part. When it comes to black justice for black people, we all need to operate in an abundance of caution. But anybody else as a victim, we see different scenarios. So if you think about whether it's how we deal with crack cocaine versus the opioid epidemic, now we understand that this is a public health crisis. Now nobody is paying attention to how much police are spending on Narcan to bring people back to life who have overdosed. It doesn't matter, because what is the value of a life? Well, as long as they're white lives, there seemed to be no amount of money we wouldn't pay. So what I think the Foundation for a Healthy Kentucky and every foundation and every philanthropic organization and government needs to do is to align in ways that invest, help. Why do we have 60% of the vacant and abandoned property in this city in the west end of Louisville? How can you live when you have fought to buy a house and 2 doors down from you is a boarded up house? And so you never see the increase in your property value. And then if it does, well, then you don't have the job to match the tax base that you're then going to have to pay, because we are overly represented in the essential workers. We need a restructuring of how we do business in this country and in this city and in this state. So what we are suggesting is, yes, my time is almost up. I know. I'm going to take 2 more minutes to wrap up.
All right.
So we are suggesting significant dollars in affordable housing, a commitment, an 18, 24-month commitment to affordable housing, and investment in small business, and not to mention some of the educational things that need to happen. And the last thing I want to tell you all is, while Louisville was protesting, so remember again, already poverty, already then the pandemic, then police brutality, and while we were out protesting the killing of Breonna, the police and the National Guard killed another man in our community. So somebody needs to figure out how to get us all access to mental health treatment, culturally competent mental health treatment. I am not quite sure why I was invited today, but I think what I've said are things that everybody needs to hear. So thank you all so much for your time, for your attention, and for allowing me to go over a little.
Thank you, Ms. Reynolds. You were invited just for that reason, because we need to hear that. We need to know that story. We need to be called on the carpet, so to speak, for what we're not doing and what we can commit to do moving forward. So I appreciate the transparency, your vulnerability. I appreciate the fact that you have kind of held us accountable. You're putting it back to ask, what are we going to do? So don't ever question why you were invited. You were invited because we needed your voice. Hopefully you can stay around with us, and you don't have to leave. There may be questions at the end. I have several, and there may be several that will continue to come in the chat box. If you have to leave, I understand, but we're going to move on at this point with our next presenter. All right.
Thank you so much.
You're welcome. Our next presenter is going to be Dr. Fran Feltner, who's director of the University of Kentucky Center of Excellence in Rural Health. She has joint appointments as adjunct faculty in the College of Nursing and College of Health Sciences, and as assistant professor in the College of Medicine, Department of Family and Community Medicine. She received her doctorate in nursing practice from the University of Kentucky College of Nursing and a master's in advanced practice rural public health nursing administration from Eastern Kentucky University. Dr. Feltner is teacher, mentor, researcher, and health advocate. She provides training for residents, graduate students, and others, and has promoted junior researchers' efforts to improve the health of rural Kentuckians. She's authored and co-authored numerous articles about rural health in peer-reviewed journals. Dr. Feltner is a compelling spokesperson for the public health of our most vulnerable populations and has testified in Washington, D.C. before multiple congressional subcommittees in support of federal patient navigation bills. She's integrally involved in training community leaders in evidence-based programming to improve public health. At this time, please welcome Dr. Fran Feltner.
Thank you, Vivian. I appreciate the invitation to be here today and what compelling stories we have. I'm going to speak to you today from the rural part of the state, and mostly Appalachia, where our community health workers are stationed in 30 counties. The Center of Excellence does serve the state, along with the state office, where we assist clinics, hospitals, and others in providing treatment during this period in time with COVID-19. It was a challenge, and as we look at what I'm going to talk about today, going the extra mile to help the underserved rural Kentuckians, how things have changed during COVID-19. When we first got the message, we never dreamed that our 25 years experience of helping rural Kentuckians and thousands of rural Kentuckians to access the health care that they need, we never fathomed that there would be a pandemic in just a few short months later. But I do want to say that because of the experience of the community health workers, because of the faith that the community has and the trust that the community has in the community health workers, we were able to move very quickly to revamp how we deliver services. And this was very important because the population that we serve is a most vulnerable population. Most all of them are at 100% of poverty. And in eastern Kentucky and in Appalachia, the social determinants of health, which we heard such a good definition when we first started today, really hit the Appalachian population. The access to the healthcare system, the lack of understanding how to navigate it, transportation, a lot of these things even multiplied during COVID-19 when things shut down. So there's a little bit about what I'm going to talk about today, and also talk about some of the solutions that we've been able to implement in the rural parts of the state. So it is a beautiful mountainous area, but it also comes with a lot of social isolation, a lot of geographical isolation, and also when people heard about COVID-19 and how it started in the cities, a lot of people that lived in the mountainous areas thought, well, that's not going to hit us. You know, we may be exempt from this. I heard that earlier, that we do live not so close proximity to each other as they do in the city, so maybe this will pass us by. But we have seen cases in rural Kentucky and some large cases in rural Kentucky. So no one was exempt from COVID-19. When you look at our Appalachian population, I just wanted to bring to the attention the underinsured rate that is still in Appalachia. When you look at the state of Kentucky, it is 7%. In Appalachia, it is 8%. In the U.S., it is at 11%. The population served by Kentucky Home Place, and my slide just went backwards, sorry, by Home Place is at 11%. And some of this is just not uninsured, it's also underinsured. People that have the high rates of their deductibles, or they have a high rate of a copay, or it is simply not covered with the insurance that they have to be able to get preventative services or to get testing that is needed during this period of time. So we were glad that some of the things were put in place to allow people without insurance to be tested and to have that access. So in the next slide, we did talk about social determinants of health earlier this morning, but I want to look at the social barriers right now. A lot of the people that we serve in Home Place, about 67% of them, have the lack of social support system, of their caregivers or of a community member that might help them at the time. And that's why it was so important to keep Kentucky Home Place CHWs working during this pandemic. Sometimes it is the only phone call that they receive from their community health worker, or it is the only contact with the outside world with the community health worker. When they are calling and checking on them to make sure that they have food, to make sure that they have the basic needs of life, and most importantly, to make sure that they can manage their chronic illness during this period of time. There was lots of questions and lots of concern and lots of fear. So during this time, providing CDC safety and preventive education was very important to the people that we serve. There was a lot of information that was being given at the time from many different sources. Could it be trusted? Did they understand the information that was being given? When you look at health literacy in Appalachia, it is very low. And so there has to be a way to communicate, and our community health workers have really been able to reach their clients and be able to give that life-saving information that the clients need during this period of time. When you look at the immediate challenges, we normally met with our clients either in a home visit or in an office visit, and this changed. Like overnight, we sent people home on March the 18th to work from home, but we saw very quickly that we had to make new policies and procedures to be able to help the people that we served. We could not just leave them without guidance, without help, without access to the things that they need when they're already at 100% of poverty and all the social determinants that go with it. So very quickly we moved to our home offices to set up. We made sure that we had we were able to adapt easily because of the strong and lasting partnerships. We have the experienced community health workers, the trust of the people that needed the services. So we were able to continue to reach out to the communities and to work with our partners to bring the things that were so needed. With technology and determination on their side, they moved to their homes. They quickly set up virtual offices. This has been a new way of meeting. They have done that very often every week to make sure that not only the community health workers are supporting the community that they serve, but the community health workers also, there has been a lot of depression, a lot of anxiety, a lot of fear brought about receiving services and how we do this. We wanted to make sure that our community health workers were supported also. So when you look at the traditional services that people in the community needed, like their eyeglasses, dentures, home heating services, a lot of these things shut down. Then they were unable to access the things that they needed. And so this facilitated the community health workers to look at new ways to be able to deliver the services that they did. They always have been an advocate or a facilitator or the communication between the clients and their providers, and then making sure that they understood their medical instructions, assisting the clients to improve their health behaviors through education. Normally, they would meet in a facility with a group of clients to deliver health education, to deliver smoking cessation, diabetes management. All of this became new during the pandemic, and changes had to be made. Some of the challenges and the needs of the clients, we'll go over those here. Businesses closed, and the soaring unemployment rates just went up every day. People were put on furloughs. They needed access to unemployment. They needed access to the different things that they could have benefits for and didn't have any idea of how to reach those benefits. Primary care offices closed, and people with chronic illness could not make appointments. Providers quickly moved to telehealth, but the clients we serve may not have had an iPhone or a phone with a camera that they could do telehealth. They didn't understand how to make a telehealth visit appointment, so the community health workers were very adamant about making sure that they had access to the care that they needed, whether it was to provide a telephone, whether it's to provide an iPad. What did they need to be able to reach their physician and to take care of their chronic diseases? Pharmacies closed. They were unable to get their chronic disease medicine. I know insulin was mentioned a few minutes ago. So there had to be different routes, like home delivery for pharmaceuticals. There had to be pickups and drop-offs and a different way of getting pharmacy. That I have to say that both of these are working much better now. Dental services completely shut down, at risk of the providers and the patients. Where it was face-to-face contact, they totally shut down. There were people calling in with dental pain, dental abscess, things that needed to be taken care of, and we are glad that these services have reopened. Medical transportation ceased. We have what's called LKLP in our community that does medical transportation in eastern Kentucky, and due to COVID-19, that shut down. Transportation was always an issue in rural Kentucky, but this made it even worse. The lack of access to personal protective equipment. I know some of the things that we've worked on is to provide materials that masks could be made, but getting the population to understand the importance of wearing a mask if they came out in public. and if they could have access to these things, did they really understand how to use it? So the community health workers were very valuable at this time. When we looked at mental health, we said that at the end of the last presentation. Wow, has that increased? The depression, the anxiety, the fear of the unknown, isolation, increase in overdose deaths. We were in another meeting yesterday that this population has really been affected by COVID-19 and the recovery services as well. I know we heard that a lot of people were let out of prison during that time, and they went back to their old habits and their addiction, and we've seen many deaths due to that, that they have come out and got access to something that might have been really strong, and so we really have had trouble with the increase in overdose in our society during COVID-19. Another big challenge was food, and I know this was mentioned earlier, but the kids were home from school starting in March, and they were used to getting 2 meals at school each day, breakfast and lunch, and all at once parents had to provide for their kids at home, and to not only be able to prepare food, but to have access to food. Our senior citizens closed. Most senior citizens ate breakfast and lunch at the center, and when the centers closed, there was not availability for them to come for their meals. Also, a short supply of items. In most of our grocery stores here in Eastern Kentucky, if the meat was available, you were allowed 2 packages of meat of any kind at the grocery store. You were, and if you didn't go early in the day, there was no meat left in the afternoon to purchase. And then you had to take your life in your hands by going into a grocery store. As one of the elderly persons told me, we're afraid to go get food. So food delivery has stopped for a while. Access to food stopped for a while. The increase on the price and just the fear of going to the grocery store really brought about a food desert like we haven't known before as far as getting food. So Kentucky Home Place was able to work. This is one of our community health workers in the slide that was able to collect food and to deliver it. And please note they did wear their mask and their gloves while they were delivering food. And some of the family members, like this is her daughter, that jumped in to help her community here with delivery of food. And so things became necessary. I am happy to say that a lot of our senior citizens buildings now are offering drive up and pick up your food delivery for the people that can come and pick up their food. And so we're working with them and others to make sure that people do have food, which is very basic needs of life. Home Place has expanded its services. We received a call from the state saying that the health care access to Medicaid was presumptive. Medicaid was going to expand during COVID-19. So very quickly, our community health workers were already assisters, and they were able to jump on board to expand their services to all 120 counties. And they are receiving phone calls every day from across the state. And eligibility only took a few minutes online with the person to get them access to the Medicaid services, to Medicaid and to the services that they need so desperately during this time. I have to say that there has been an increase in people calling, and we are hoping to help every individual. There is a list, a contact information list here on the slide. It is very small on the slide, but you can have the phone numbers listed of all 22 workers. And if one doesn't answer the phone, the next one will. So that is a service that has been added to Home Place. Looking at our census in our state, our community health workers also joined with the 2020 census. You know, we're living in COVID-19 right now, but when this is said and done, there are other things that will take place, and our census is very important, that people go and do their census, but a lot of people do not understand how to do that, or they're afraid to put their information in. And so our community health workers are trying to increase the numbers, particularly across our state. Rural is very low right now. If you look at the numbers in the map there, and the orange counties are the counties with the lowest amount of people that have completed their census. So they are on a campaign now to make sure that as many people as possible sign up for the census that will help us in the future for funding in our communities. Also, when we talked about the children at school and the food that they got at school, there has been a push for these will be food benefit programs for students that are in schools that have low or reduced lunch or complete lunches at schools. The program that our students can now, families can now go online and apply for a food stamp card that will give them $313 per student to help with replacing those meals and the income while the students are at home. So community health workers have partnered to train and be ready to help the people as well. Another resource that came out was the stimulus payment. And so we also trained our community health workers with the government benefits unit manager and the legal aid of Bluegrass regarding the people that do not fill out taxes to be able to reach the stimulus payment and the funds that they so desperately needed during this time to be able to have food and other things. So in summary, when I'm looking at what our community health workers have done, we do have, my slides keep moving on me here. They have adapted service delivery and are meeting the ever-needing change of the people that they serve. And they've had 25 years' experience at doing this. But I have to say that during COVID-19, this has really been a challenge, making sure that people have the right information, make sure that they have access to the things that they need, and most importantly, the basic needs of life in order to continue to live during COVID-19. They have also been able to help with access to health care in a different way. Different rules and regulations were put in place for telehealth and even a telephone visit that patients so desperately needed. We've been able to change our database to be able to track what Kentucky Home Place is doing with the population that they're serving. And I have to say that the community health workers are so resilient. We hear in their voices every day when we come online to help with another issue how important it is to them to get the supplies and how important it was to get food to the clients when there wasn't a delivery volunteer available, how important it is for them to make sure that they have a medication assistance so that people with diabetes that are without insulin can get the medications that they need. If they run into a roadblock, I love this, they call each other or they call their community partners to develop an alternative, and they've been very successful at that. So as I think about how community health workers, how strong they are and how committed they are to the people that they serve, I also think about the community members and the clients that they serve and how much they depend on the community health worker to be an advocate for them, not only during COVID-19, but during a normal period of time when we are not in crisis. They are in crisis. They are in need. They live in 100% of poverty. They are in need of the vital services to live each and every day and have the ability to be heard of the needs that they might have. They do have this great partnership, and I have to brag on our partnerships throughout our communities. It was a time when we came together to make the mask, to give people protective equipment, to make sure that they had food, to make sure that they had the essentials that they needed to prevent COVID-19, to make sure that they understood the social distancing, to make sure that they understood the different changes and guidelines that came down each day to protect them. So by ending this, I say that our community health workers have gone the extra mile during the COVID-19 pandemic to continue to help the community that they serve. And I appreciate you, Vivian, for being able to come on and talk about our Appalachian and our rural population that are so needed to be taken care of and to be heard. And so I appreciate the time this morning.
Thank you, Dr. Feltner. Appreciate the rural perspective. I want to interject here and say I'm sure we're going to go over our time. And before I introduce Heather Howard, I want to ask you if you don't mind hanging in with us to hear our last presentation. I think it's going to give us a perspective of what other states surrounding us are doing, how Kentucky can do better. because the Maya Angelou quote, if you know better, you have to do better. And to paraphrase her quote, I want us to kind of see what other states around us are doing, and maybe there's something that we can learn and grasp from them to do better. So stay online with us if you can. Give us a time to kind of process all those presentations, ask a few questions, and hang on to give us positive feedback on how you felt about this particular webinar. So I'd like to introduce our last presenter. It's Heather Howard. She's the program director at the State Health and Value Strategies, a program of the Robert Wood Johnson Foundation that's focusing on assisting states and transforming their healthcare systems to be more affordable, equitable, and innovative. Heather leads the SHVS and assists states in their efforts to transform health and healthcare by providing targeted technical assistance to state officials and agencies. She lectures in public affairs at Princeton University's Woodrow Wilson School of Public Health and International Affairs, where she teaches a course on health policy and administration and is a faculty affiliate of the Center for Health and Wellbeing. She serves as New Jersey's Commissioner of Health and Senior Services from 2008 to 2010, overseeing a cabinet-level agency with a budget of $3.5 billion and a staff of 1,700. She's received her J.D. cum laude from New York University School of Law and her B.A. cum laude from Duke. Without further ado, Ms. Howard.
Thank you, Vivian, and thank you, everyone. It was really powerful to hear those Kentucky voices, and I hope I can add to them now by helping pulling back a little bit and thinking about what's happening in other states and what lessons that might be applicable for Kentucky. It was so well established that we are dealing with twin epidemics now converging and bringing into stark relief the structural inequities that are exacerbating health disparities and the importance of centering health equity in recovery policies. And so what I'm going to do is, and there's a lot of good information in these slides that I know they'll make available so folks can go back and look more closely, but I want to just give you a sense. We've stepped back and we've developed what we think are 5 key questions that policymakers should be asking right now in their COVID-19 response and recovery efforts to advance health equity. So trying to be concrete about what steps you can take right now to improve your response and embed equity in that response. So jumping into question 1, and I think Vivian, this person is probably you, doing a great job. Is states need to ask: have we identified a person or team of people to apply an equity lens to all of our COVID-19 response work? And this first example, just looking a little bit east to North Carolina, Governor Cooper in North Carolina created a health equity task force to identify best practices. And I would note Sadiqa made such a compelling point about the importance of economic equity, and this task force in North Carolina is rooted in the health response, but looking more broadly at economic stability and environmental justice. So North Carolina is an interesting example of centering equity in the COVID-19 response and in that broad way. I would also look to Michigan, where we know they have had a significant number of COVID-19 cases, and the governor there created a task force on racial disparities, which is looking at improving its data reporting and then using that data to inform the state's response. And to build resiliency coming out of the pandemic. So those are a couple. And then here's a third one. Ohio created a minority strike force. That's the language they used to investigate and respond to the COVID-19 disparities they were seeing. And they've already released their first report, the strike force, and made several recommendations, especially focusing in early on the importance of expanding access to testing in communities of color. And that's resulted in the state creating walk-up and drive-up testing centers in most hard-hit communities. So those are 3 examples of that first question, is how do we make sure we've got the right people at the table, making sure equity is part of our response. The second question is, are we identifying at-risk populations and targeting resources specifically to those populations and using cultural competency to do so. And Virginia provides a good example here, where the Commonwealth has been working with the city of Richmond to make sure that PPE, personal protective equipment, is going to those communities most affected. Virginia also has a health equity leadership task force, which is helping to drive this work and make sure that their resource and responses are being targeted. North Carolina is also focused on ensuring equity in their relief funds. And again, to Sadiqa's point about the economic impact, North Carolina's working with historically underutilized business program they have to advocate for the minority-owned businesses and using their own Department of Commerce to guarantee equitable distribution of some of this relief funding. If you look at New York, which obviously has been significantly impacted, they're also focused on, like Virginia, on targeting their testing on communities of color, and they have pioneered a partnership with churches in predominantly minority communities to make sure that testing initiatives are most focused on those affected communities. The third question is a tougher one to think about, but I think a really important one, which is, have we issued any guidelines that foster health inequity? Meaning, we start by saying, are we targeting our resources in a way that reach those communities that have been most overlooked and that are most affected in this pandemic? But I think you also need to ask yourself, are we doing anything that might be exacerbating inequities? And I don't have any state examples here, but I think you can imagine some of the things you want to look out for. Has the state, for example, might a state, when it's thinking about how to use limited resources, might they be allocating those in a way that leaves certain communities out? Alabama initially released a prioritization for ventilators that excluded people with intellectual disabilities, and there was an outcry, and they quickly rewrote that prioritization criteria. But it's something to think about: is everything we're doing, could we be exacerbating disparities? Going to the next one, question 4 is a data question, which I know is near and dear to the hearts of our presenters here. Are we collecting our data, displaying it for the public? Are we doing a good enough job as we can to report the data from the pandemic in such a way that can support policy responses that ensure we're being equitable in our responses? And we know this isn't easy. Even when there's a will, it can be hard, because we know state agencies are very resource constrained because of the economic downturn and maybe years of underfunding in departments. It's very hard. And so we've produced some, you'll find on our website, some reports on best practices for reporting this data, but it's really important to identify what sources you're calling from, where you might be missing data. But the more you can report your data by race and ethnicity, and by as granular as possible a geographic component, the better that can support policy interventions. And of course, the data reporting may never be as good as you'd like it to be, but it's important to get started and then continue to iterate on that data reporting. I have some examples. Indiana, here's an example of how Indiana benchmarks their data reporting by race and ethnicity against, not just in the aggregate, but against the percentage of the population. So that gives you a sense of, so you can see where you've got a disproportionate impact. And again, I would make a plea for, if you can, to be reporting data down to as granular a level as zip code, so you can really see where the disparities are greatest and then target those interventions. The good news is that the federal government, pursuant to Congress, required HHS in their CARES Act legislation, is requiring HHS to require states now to report data by age, ethnicity, race, sex, and zip code. So that data is being reported by Later this summer, there'll be more data coming into the feds, which I think will help support responses. Kentucky is doing a good job with its reporting. It's reporting cases by a number of categories. Here are a couple other categories Kentucky may want to think about. Including zip code, underlying health conditions, and healthcare workers. The more robust your data reporting, obviously, then the more robust your understanding is going to be of the epidemic and its disproportionate impact on marginalized communities. So this gives you an example. And this is a link you'll see. There's a hyperlink in the bottom of the slide to a report we did comparing how states are reporting their data, their health equity COVID-19 data. And you can go in and you can look and see how Kentucky's doing, how other states are doing, and get ideas for how to support your data. And Kansas has done an interesting job of marking their testing rates by race and ethnicity, which I think is really interesting and worth exploring. And Chicago is also building in equity into its benchmarking to determine how well they're doing in managing the epidemic, and then informing their reopening decisions. So they're not just saying, well, what do our overall caseloads look like? What does the data look like by population? So that we're not making decisions, again, back to my question number 3, we're not making decisions to reopen that may exacerbate some of those disparities. Now that fifth question, I know I'm moving through these quickly because I'm sensitive to everyone's time, but you'll have access to these slides. I think a really important one, especially I know we have many community-based organizations listening in, is the state or policymakers collaborating with community organizations and members of those heavily impacted neighborhoods to address the gaps in outreach and build trust. And that's going to be so important as we're moving to recovery and as we're focusing our testing strategies. How are we doing it in a way that builds trust? Are we sending government workers out into communities in a way that reflects the communities they're serving, where there is trust, or are we going to be exacerbating some of those trust challenges that we're facing? It's really important to be thinking about it. And Ohio, I think, is an example I would point you to. That strike force recommended partnering with community health centers to increase testing rates in communities of color and other high-risk populations, and hiring public health workers that reflect the makeup of their own community. And we obviously just heard from Fran about the incredible role community health workers can play. In New Jersey, the governor just this week unveiled their contact tracing initiative and spoke powerfully about intentionally integrating equity into training of those contact tracing workers and their public outreach, with a particular focus on social justice and integrating and health equity and privacy into these contact tracing. I think there are many, many risks in contact tracing not being done right. So it's so important to incorporate these social justice and health equity principles into the contact tracing. And I think New Jersey at least is one model. It's just the beginning of the process and something we want to continue to watch. I would put a special point here about Latinx communities and making sure that the state emphasizing that contact tracing is not going to be collecting immigration information. And New York City is also unveiling its contact tracing effort, and with a real attention focused on the hardest hit neighborhoods and reflecting the communities being served. So important to do. And finally, as I sort of wrap it up, as we're shifting from responding to the crisis, which is obviously ongoing, but thinking about reopening and recovery, how do we incorporate equity in a way that strengthens the response and mitigates rather than exacerbating pre-existing disparities and meets the needs of the states and localities? And a lot of important work going on in Kentucky. I have been so honored to hear about that great work, and I hope that this look at other states and what's happening around the country will be helpful to you all as you continue this important work. I would just note, too, that we have a resource page where you can go and you can find links to a lot of the resources I mentioned. If you go on our website, shvs.org/COVID-19, we have a health equity tile you can click onto and find a lot of these resources. With that, I'll turn it back.
Thank you so much, Heather. I've enjoyed all the presentations today. I think they've all given us food for thought, given us different perspectives to think about, and how all of these intersect into the COVID pandemic that we've experienced across the country. I just want to take a moment to thank the Foundation for doing this. I think it's something that we need to start talking about, not just as a foundation, but to have conversations among our peers and colleagues and friends about what we can do better the next time something like this happens, and not just with the pandemic, but how can we do better moving forward as a state, as a nation. I want to make sure that we have a chance to get one question or two per presenter. If you'll hang on the line with us, I just need to check to make sure. Fran, are you still with us? Heather, are you still with us? Dr. Fernanda and Ms. Reynolds, are you still with us?
This is Fran. I'm
This is
here.
Heather. I'm still on.
Okay. Is Dr. Fernanda or Sadiqa still with us, Ms. Reynolds? All right. I do have a question for Dr. Feltner and for you, Ms. Howard, if that's okay. If you just give me the liberty to ask you one or two, and then
Sure.
We'll close out this webinar. So, Dr. Feltner, I'll start with you. So, the community health worker model, you've presented to us that was critical in addressing the COVID-19 response in Appalachia, Kentucky. What about if and when the pandemic resurges, how should that model be used to expand it across Kentucky? How do we go about making sure that other communities use this model?
That's a very good question, and something that is deep in the love of my heart, Vivian, is that all of our counties need Kentucky Home Place, not just during pandemic, but most important during pandemic, because the trust is already built in the community when you have that community health worker model there, that you are hiring people from the community that understand the community, that are part of that community, that are able to communicate in a way that is understood and accepted. And that community health worker has the understanding of that community and what their goals and their beliefs and their ways of life are. And so it's easier when you have that model in place during a pandemic to reach out to the community that needs the services, that needs the information, and you have that infrastructure ready to help the people.
Right. Yep. You know, I'm a big proponent of community health worker model, so I'm glad to hear that. And so, Heather, for you,
Thank you.
I appreciate all the different plans that you've given us to look at for our neighboring states and some that don't neighbor us. But out of those 5 key questions for the state, if you had to list one as a priority for us in Kentucky, what would you tell us to do first?
Well, I think it all starts with data. The better the data reporting, the better the policy response. And I think Kentucky's doing a good job, but I think it's always integrating that data into your response, and then so that it can drive the response, and the public reporting of that data is so important. As we talked about, the whole policymakers accountable, and you've got some great initiatives going on. The governor's announcement just this week about the expansion of health insurance. But having sufficient data to ground good policies can drive, is the best way to address inequities, and especially in resource allocation.
Okay, perfect. And this is a question for both of you all, or those that are left on our presenters that are left on the line. We recognize that the essential worker, that those on the front line, were not necessarily the folks that we could tell to self-isolate at home. How do we go about protecting the essential worker and their families should this pandemic arise again? And unfortunately, we are getting the forecast that we're in for a second wave. So from lessons we've learned, what can we do to make sure that people want to know their status, want to be tested, and don't have to worry about the livelihood of their families?
This is Heather. I'll start. I mean, that's such a good question. I think one thing we're seeing in some states we're tracking now is planning for a second wave, and you may need to plan for alternate housing solutions for workers, right? So it starts with testing and a robust testing and contact tracing program. But for some people who can't self-isolate at home, like you just mentioned, there may need to be alternate arrangements. And we're seeing in New York and New Jersey, the states that were sort of hardest hit first, they're making plans to even sort of renting out hotels so that there will be places for people to isolate if they can't safely do so at home, given, there may be a variety of reasons that they're not able to do so at home. So, and relying on FEMA dollars to do so. So that's one idea. And I'll jump in too. I think that's where those. And I think that's where those partnerships with community-based organizations are so important. That organizations, in the communities have those relationships and can help foster both the testing so that people are tested and the contact tracing, and then can help identify people who can't safely self-isolate at home, can be the bridge to maybe those kind of solutions.
Vivian, when you think about it, the essential workers are really putting their life out there for us to provide the health care for us. And really, their families should have priority to testing or whatever the resources are to keep them working if they can't self-isolate. I know, speaking of this, I had a cousin that passed away due to COVID-19. And he was seen in the emergency room and told to go home and self-isolate. And he died that night in his bedroom. But he got critically ill and passed away that evening. And so we don't want those things to happen when we tell people to go home and isolate, particularly for our essential workers. It is so important to them and their families. And, they still have families that they take care of, not just at work, but, with the patients, but they still have families. So I really do think we have to make special arrangements for them that are putting their life out there for us each day.
Yeah, I do agree. Those essential workers that not necessarily are our doctors and our nurses, but you're right.
Exactly.
Those essential workers that are, yes, absolutely. All right, I want to not take up any more of your time. I thank you all for those that have stayed on the line to hear the conversation and discussion around addressing inequities in the COVID-19 response, especially relates to our minority and marginalized vulnerable populations in Kentucky. Please take the survey that may follow asking you about this webinar. We want to continue to have this conversation. I will say I'm so glad that Ms. Reynolds put the foundation to the task of doing more, having conversation, actually putting our money where our mouth is, so to speak, and to really addressing the hard questions. I also want to thank Dr. Fernanda for kind of giving us that historical perspective and kind of giving us a roadmap as to where we need to start thinking and planning in the future. To Dr. Fran Feltner for giving us the rural perspective and how important that is in such a diverse state as Kentucky. I think we are diverse in geography and more so than maybe we are in other demographics as far as race, ethnicity. I do want to thank Ms. Howard for presenting something for us to think about and to model other states and how to prioritize our response in Kentucky moving forward. I will say in closing that the State Department for Public Health is looking how to make our data collection system more robust and how to look at some of those additional questions that you posed for us as to looking at zip code and even down to the census tract level in high-risk populations and neighborhoods across the state so we can be more effective in our testing and services in responding to those unmet needs related to not only COVID, but looking at other services as well. And we're also looking at our essential workers. Are they more, what's the story? Some qualitative information that's being collected during the contact tracing portion, and really trying to make sure we address some of those social determinants and upstream factors that have been revealed in relation to the COVID response. So we are working, trying to do better at both a state agency, and I challenge the foundation to do so as well. Please provide additional questions in the chat box, and we'll make sure that the presenters have those. This will be archived on the foundation website. Stay tuned to receive that link. Again, we thank you, and we want you all to go out, have a productive rest of the day, enjoy your weekend, stay safe, and stay well.